Thank you, everybody. We are ready to reconvene. It is, apologies, 36 after the hour. And we will move ahead with the next session on immunization schedules. Oh, Dr. Alt. Dr. Alt is also the chair of this immunization schedule, adult immunization schedule work group. So I'll turn it over to Dr. Alt to talk about recommendations from the combined immunization schedule work group for 2022 for children, adolescents, and adults. Thank you.
Thank you. I will try to speed through this, but Dr. Woody and Dr. Morthy, if I miss anything, please correct me at the end, or anybody else who knows this is a problem. So next slide. The combined immunization work group updates the child, adolescent, and adult immunization schedules annually. The child and adolescent immunization schedule summarizes ACIP vaccination recommendations for persons 18 years of age or younger. And the adult immunization schedule summarizes ACIP's vaccination recommendations for persons 19 years of age or older. The goal of the combined immunization schedule working group is to better harmonize the child, adolescent, and adult schedules. Next slide. I want to acknowledge Dr. Bernstein briefly, who was on the committee or co-chaired the committee actually, until he rotated off the ACIP committee earlier this year. Next slide. And we recruited a new member, Dr. Sineas, who you've heard talk a couple of times because she's on the hepatitis B group as well, but we'd like to welcome her to the group as the new ACIP member. Next slide. The working group began with 5 ACIP members this year, including myself and Dr. Hank Bernstein as co-chairs, and ended with 3 ACIP members and still with me as chair. I'd like to acknowledge our liaison representatives listed on the left side of this slide, our work group consultants and co-leads listed on the right side of this slide. Next slide, please. And I want to acknowledge the CDC subject matter experts who've contributed to our work group's activities. Next slide. Presentations on revisions of both schedules may include the use of vaccine trade names. This is for identification purposes only, and does not imply endorsement by the CDC. The proposed edits that will be discussed are subject to change based on ACIP's discussion and vote. Next slide. I'd like to remind our committee that and the audience that we present this schedule for a vote every fall. The ACIP's approval is necessary prior to publication of the schedule in January of the following year. In addition, ACI approval is necessary before we have our partners from other professional organizations that are listed here on the slide to review and approve this schedule. Of note, this is the first year that the Society for Healthcare Epidemiology of America will be listed as an approving organization for the ALT schedule, and we welcome them and their input. Finally, no new policy is established by this schedule, but rather it reflects ACIP recommendations. Next slide. For the remainder of this presentation, Dr. Bodie will discuss the proposed edits to the 2022 child and adolescent schedule, and Dr. Morthy will discuss the proposed edits for the 2022 adult immunization schedule. These edits are intended to incorporate ACIP recommendations and MMWR publications that have occurred since October 2020, improve the readability and utility of the schedule into language that is easy to interpret for the busy provider. In addition to harmonization for both schedules, there are proposed edits to the table, content changes in the note sections, in addition of an appendix listed the contraindications for precautions for each vaccine type. The session will conclude with a discussion of the proposed edits, followed by a vote on the adult schedule and child and adolescent schedule later this afternoon. I'm going to ask Dr. Woody to go through the proposed edits for the child and adolescent schedule.
Thank you, Dr. All. Good afternoon. I'll present the proposed edits for the 2022 child and adolescent immunization schedule. Next slide. On this slide is a list of ACIP votes relevant to the child and adolescent immunization schedule that have occurred since October 2020. The 2022 schedule has been updated to reflect ACIP's recommendations for use of dengue vaccine and the 2021-22 influenza vaccine. In addition, clarifying edits were made to sections of the tables and notes to improve readability and the utility of the schedule. An appendix listing the contraindications and precautions for each vaccine type has been added to the schedule. Next slide. First, I'll present changes to the table, then the proposed edits to the notes section, and I'll finish with an overview of the appendix. Next slide. Now, beginning with the edits to the cover page. Next slide. To harmonize with the cover page of the adult schedule, we have included a section with information on how vaccine providers can contact CDC with questions and comments about the schedule. We have also included a link to the web page housing the vaccine information statement. Next slide. A QR code has been placed on the right lower corner of the cover page. Next slide. Scanning this QR code will take providers directly to the online version of the child and adolescent schedule. Next slide. Now, in the box describing how to use the schedule, we have included a fifth step instructing providers to review the newly added appendix, which lists the contraindications and precautions for each vaccine type. Next slide. Finally, to the cover page, we have added a row for dengue vaccine to the table of vaccine abbreviations and trade names. Next slide. Next are the proposed edits to Table 1, which is the graphical presentation of the routine immunization schedule by age. Next slide. Now, Table 1 now includes a row for dengue vaccine, with the columns for age 9 through 16 years shaded in yellow to indicate the recommended age for vaccination. In addition, we have included the overlying text, seropositive in endemic areas only, see note. Next slide. In the HPV row, the work group made a change to the column for age 9 through 10 years because the descriptive text in the blue box within the legend includes the phrase shared clinical decision making, and some providers found this confusing. The work group decided to have a separate color to represent the recommendations for using HPV vaccine in this age group. The blue color has now been changed to a new checked yellow color, and within the legend, a checked yellow box has been added with the descriptive text. Recommended vaccination can begin in this age group. The blue box within the legend has been revised to delete both the asterisk and the descriptive text can be used in this age group. Next slide. In the TDAP row, the overlying text in the 11 through 12 years column has been changed from TDAP to 1 dose to be consistent with the other rows in the table. Next slide. Finally, in Table 1, we have removed the emphasis on the columns for ages 4 through 6 years, 11 through 12 years, and 16 years by changing the color from gray to black to make similar to the other columns in the table. In addition, the sentence in the header which stated full entry and adolescent vaccine age groups are shaded in gray has been deleted. The rationale for this proposed edit include the following. Emphasizing this age columns is not a part of an ACIP recommendation, and providers should review vaccination status at every encounter. However, some work group members indicated a preference for continuing emphasizing this age column as a way to prompt providers to check vaccination status during specific periods, particularly during adolescence. Next slide. Table 2 outlines the catch-up immunization schedule for children and adolescents who start their immunizations late or are more than 1 month behind. Next slide. A row has been added to Table 2 for dengue vaccine, showing the minimum age for dose 1 and the minimum intervals between doses. Next slide. In the HPV row, The text in the minimum interval between those 2 and 3 has been updated to include Vaxalis in the 4 weeks interval and to delete Converse from the 8 weeks interval. Converse was discontinued in 2014, and all children who receive Converse will be past their 5th birthday by January 1st, 2022. Next slide. Next, I would highlight the changes to Table 3, which is the graphical presentation of recommended immunizations based on medical indication. Next slide. The subheader for CD4 count and percentages was changed from less than 15% and total CD4 count of less than 200 lymphocytes per cubic millimeter to less than 15% or total CD4 count of less than 200 lymphocytes per cubic millimeter. This change was made to be consistent with ACIP's general best practice guidelines defining HIV laboratory parameters for severe immunosuppression. Next slide. For clarity, the descriptive text in the red box within the legend was changed from not recommended / contraindicated to contraindicated or not recommended. In addition, the descriptive text linked to the checked yellow box was revised to include all vaccines. It now reads, vaccination is recommended and additional doses may be necessary based on medical condition or vaccine. See note. Next slide. The final edit to Table 3 is the addition of a row for dengue vaccine, indicating the vaccine is contraindicated in persons with immunocompromising conditions, including those with severe immunosuppression due to HIV infection. In the columns for pregnancy and persons with HIV infection who do not have severe immunosuppression, we have used the orange color to point out that the vaccine might be indicated if the benefit of protection outweighs the risk of adverse reaction. Next slide. Now, moving on to the proposed changes to the notes section. Next slide. For COVID-19 vaccination, in addition to stating that COVID-19 vaccines are recommended within the scope of the emergency use authorization or biologic license application for the particular vaccine, we have added the phrase or has otherwise recommended by ACIP and adopted by the CDC director. Also included is a link to the web page outlining CDC's interim clinical consideration for the use of COVID-19 vaccines. Next slide. Dengue vaccination has been added to the notes section to summarize the recommendations for routine vaccination and provide guidance on geographical areas where dengue is endemic. When available, we would also include a hyperlink to a web page with additional information on pre-vaccination laboratory testing and dengue endemic areas. Next slide. Now, within the HIP notes, the routine and catch-up vaccination section has been updated to include Vaxalis. A notation has also been added indicating Vaxalis is not recommended for use as a booster dose. Next slide. A minor edit has been made within the hepatitis A notes to clarify the age for routine vaccination is 12 to 23 months. Next slide. Within the hepatitis B note, the introductory sentence in the special situation section regarding recommendations for revaccination was updated to include post-vaccination serology. It now reads post-vaccination serologic testing and revaccination if antibodies to hepatitis B surface antigen is less than 10 milli-international units per millimeter is recommended for certain populations, and the populations are listed below. Next slide. Now, within the HPV note, the final bullet in the routine vaccination section has been edited for clarity and now reads, no additional dose recommended when any HPV vaccine series has been completed using the recommended dosing interval. In the special situations section, the bullet on immunocompromising conditions has been revised to clarify that a 3-dose series should be administered regardless of age at initial vaccination. In addition, the sentences in the pregnancy bullets have been rearranged and now read, pregnancy testing is not needed before vaccination. HPV vaccination is not recommended until after pregnancy. No intervention needed if inadvertently vaccinated while pregnant. Next slide. The special situation section in the influenza note was condensed by deleting previous bullets outlining the contraindications and precautions. Healthcare providers are now referred to the appendix, which lists the contraindications and precautions for all types of influenza vaccines. Next slide. Within the MMR notes, the routine vaccination section was updated to include the use of MMRV. In addition, we have included language stating that for children aged 12 to 47 months, it is recommended to administer dose 1 as separate MMR and varicella vaccines. MMRV may be used if parents or caregivers express a preference. We have also included a bullet stating the minimum interval between MMRV dose 1 and 2 is 3 months. Next slide. In the meningococcal ACWY note, we have included language stating that men ACWY and men B vaccines may be administered simultaneously if indicated, but at different anatomic sites if visible. Next slide. Similar to the MMR vaccination note, MMRV has been added to the varicella note, including the language for children aged 12 to 47 months that states that administration of dose 1 as separate MMR and varicella vaccine is recommended. MMRV may be used if parents or caregivers express the preference. Now for children aged 12 months to 12 years, the text in parentheses providing guidance for when dose 2 is administered less than 3 months after dose 1 has been revised to clarify this refers to inadvertent administration. It now reads, a dose inadvertently administered after at least 4 weeks may be counted as valid. Next slide. Finally, I'll go over the appendix, which is a new addition to the schedule. It includes contraindications and precautions for each vaccine type included in the child and adolescent schedule. At the top of the appendix, we have, next slide. Next slide, please. At the top of the appendix, we have a statement noting the appendix is adapted from ACIP's General Best Practice Guidelines for Immunization and from the 2021-22 Influenza Vaccine Recommendation. Also included is a hyperlink to the web page for CDC's interim clinical considerations for use of COVID-19 vaccines, which lists the contraindications and precautions for COVID-19 vaccines. Next slide. Now, on the first page of the appendix, we have a list of the contraindications and precautions for each type of influenza vaccine. Next slide. And on the second page of the appendix, we have a list for the contraindications and precautions for non-influenza vaccines. Next slide. That's all I have today. Thank you for your attention. Now, pause here and take questions. Thank you.
Thank you. This presentation is now open for questions. Dr. Daly.
Yeah, thank you so much for that. Could you go back to the visual display of the childhood immunization schedule? I didn't write down what slide that was on. But...
What slide was that?
Well, it was probably So it was the visual display of the childhood immunization schedule. So probably,
Page 13, I
Was
think.
it a table?
the colored,
Okay.
yeah, so it's like, Dr. Laird thought it was slide 13. So yeah, thanks. Or yeah. Childhood. Actually, if we could move forward, I'd rather comment on the one that has the contraindications but my comment's going to be relevant to both. So I guess the question I have, Dr. Woody, and thank you for running through all this with us. The question I have is, at what point does the complexity of the schedule make it sort of nearly impossible to display in a visual format? I would make a couple comments. One is, I think, so yeah, not this one, but the one that's got the colors for contraindications, et cetera.
Okay, that's table 3.
Yeah, thanks. Sorry. Sorry about having
Just give me a
trouble
minute.
find it. No, there we go. Okay. So yeah. So yeah, I mean, I guess my question is kind of at what point does the complexity make it hard to display visually, and whether the work group talked about that, and whether we get any sort of, focus group type feedback. I mean, I myself, I'm a bit colorblind, and so sometimes it's a little hard for me to kind of work through this. But at the same time, I think that this is still sort of photocopied and laminated and put, thumbtacked onto the clinic wall, and then it's really quick. But I just am a little bit concerned about, every time we add a new color, it just makes it a little more hard to interpret. So that's question one. And then a related question is whether any of this is available in an app, and if we know whether immunization providers are using that as a means to assess this information. Thank you.
Thank you, Doctor, for your question. Yeah, the schedule is available as an app, and I don't have any data or information on how well providers use the app. And I could see if we have that data available. Now, when we decided to change the color in table 1 for HPV, we understand that we understand the issue about having too many colors. So we decided to use a color that's already on the schedule. So in the entire schedule, we did not introduce a new color. We just used a checked yellow color that was in the previous part of the schedule. The schedule can be accessed online and printed online, and we have a colored version and a grayscale version, a black and white version. And we're working with our graphic team to ensure that both can be used by people who have color blindness. Does that answer your question?
Yeah, I mean, it certainly does, and I really appreciate all the work. I guess there's still this fundamental question about what's the best way to graphically display the complexity of all of this, and I don't have an answer. I just think it's challenging as every year it gets a little more complex. Thank you.
Thank you. Dr. Brooks?
Yes, thank you for that presentation. I just have a question regarding a statement you made that these recommendations must be approved by certain organizations, the AAP, AAFP, et cetera. Has that always been the case? And what does that mean in terms of they must approve it?
Yeah, it has, I don't know for how long, but we have partner organizations that work with us while we are putting the schedule together. And then after the schedule has been voted on and approved, they also approve the schedule.
Okay, so you mean they approved it before it came to us, and then now you're saying this is coming to us with their approval. Is that what you're saying?
It's coming to us with their input. They have representatives in the work group.
Okay, that clarifies it. Thank you.
Thank you. Dr. Lair?
Thank you. Could we please go to slide 14? And I'd follow up on what Dr. Daly said. If you look right underneath the box, the front page, it's on slide 14, there's the link to the app. And I would like to strongly recommend the app. Has proven incredibly useful to me over many years, and I probably open it up 3 or 4 times a week to get answers to specific questions. So I'm very thankful that that app is highlighted on this page. Thank you.
Thank you. We're going to move to Dr. Alt.
I just wanted to clarify for Dr. Brooks, I'm part of the ACOG committee that looks at these recommendations. After we vote today, somebody from the American College of Obstetricians and Gynecologists usually sends these around and we give it a thumbs up. So I can't speak for how other organizations handle it, but that's how we do it at the American College of OB/GYN.
And so if I may real quickly, so what happens if you guys give it the thumbs down? Does it come back to ACIP?
I don't know that that's ever happened before, mainly because we spend so much time with the liaisons and in these committee meetings. So I don't know if there's precedent for that. So I don't think I know the answer to that.
So this is Melinda Wharton. Because of the involvement of the groups in the work group, the schedule is really developed collaboratively. And so if there are late changes, they are worked through by the group as a whole. So although there are formal processes for approval, it tends to work actually pretty seamlessly.
Thank you.
Thank you. Ms. Coyle.
Thank you so much. I just wanted to expand upon some of the capabilities of IIS and just make sure that folks are aware that one of the key features of immunization registries are that they can evaluate what somebody has received in the past, so any doses they've already had, and then also look at it compared to the ACIP recommendations, which then can forecast what that person is likely recommended to receive. Obviously, that can aid in any decision making that the provider needs to make in conjunction with the patient. But that is a key feature of an IIS, and I would just put that out there for folks to consider. Thank you.
Thank you. Dr. Brooks, do you have another question?
No. And
Thank you. Dr. Long?
thank you.
I have a very minor point. I'm sorry, I lost track of the slide, but it's the one that you talked about, the coronavirus recommendations. And it was a process inclusion about emergency use authorization and the recommendation of the ACIP and the adoption of the Centers for Disease Control. And since we know that doesn't always all flow in that direction, I wonder why you put that in there and if you just might leave the process out.
Yeah, sorry, I'm trying to get back to the slide. We actually worked with our Office of General Counsel for the language to help us guide the language. And the recommendations can be within the scope of the EUA or the BLE, or as recommended, or if there's a recommendation by the ACIP that's set by the CDC director.
But recommended and adopted are not always correct, have not always been correct. So I'm surprised that legal approved that, but if they did, I certainly don't want to revisit the decision. I just wonder why you put process in this one and you put process in no other one. And in this case, we're not in synchrony for one decision.
Yeah, I'm going to ask Dr. Wharton to comment.
Yes. So this is part of the ACIP standard process, but we can consider this wording.
Just to clarify, I want to make sure, Dr. Lang, I understand your point, which is it seems this is consistent with what the charter is, but why put it in this particular recommendation, correct? So it should come out? Is that what you're asking?
Yes, that's my question.
Okay.
Why put it in?
Okay. I will ask if the CDC team can confer with the CDC team and clarify that, because I also don't understand why it should be in there, because it's just a part of the charter and it shouldn't be in every single recommendation, nor is it unique to this particular one. So thank you for pointing that out.
Thanks.
Dr. Goldman.
Thank you. It'll be real brief. 2 points. One, I really appreciate the updates, especially the contraindications. I think that is very helpful for physicians who are vaccinating. And I would postulate that as robust and somewhat confusing as it looks at first blush, most of those who are doing vaccinations will digest this information and use this less as a reference, because they'll integrate it more into their practices to become more familiar. But I'm really appreciative of how robust the information is. And to Dr. Brooks' point, at least the way the American College of Physicians handles it, once it's approved by CDC, I take this back to our vaccine committee, which then votes and brings that up to the Board of Regents. And when they approve the policy on the executive, it's published in the Annals of Internal Medicine. So for the most part, it is usually in concert, but sometimes they won't always agree. And if that happens, they just would publish the policy differently in the Annals of Internal Medicine. But for the most part, it really does support the CDC guidelines.
Thank you. I don't see any other hands raised, so I think we should move forward to the adult schedule presentation. So Dr. Neil Murthy will present on proposed changes to the 2022 adult schedule. Dr. Murthy?
Dr. Lee, give me a moment as I pull up my slides. Sorry, give me 1 minute. All right, can everyone see my slide deck? Is that fine?
Yes, we can see it. Thank you.
Okay, perfect. Well, thank you again, Dr. Lee. My name is Lieutenant Commander Neil Murthy, and along with Dr. Patricia Wody, I serve as the co-lead of the Combined Immunization Schedules Work Group. And this afternoon, I'm very grateful to have the opportunity to present all of the proposed updates to the 2022 adult immunization schedule. This is an overview of what I'll be covering in the next couple of slides. I'll present only substantive changes to the 2022 schedule. Minor grammatical or formatting edits that are meant to improve clarity in the language will not be presented. I'll begin this discussion by walking through the proposed edits to the tables, followed by a discussion of the proposed vaccine-specific changes in the notes section, and finish with a brief overview of the appendix, listing the contraindications and precautions to each vaccine, which is a new addition to the schedule this year. Let's start with the cover page. There are 4 main changes on the cover page. The first is in the How to Use the Adult Immunization Schedule box, where we have included a step instructing providers to review the newly added appendix that lists the contraindications and precautions for all of the vaccines listed in the adult immunization schedule. The second edit is in the box in the upper right-hand corner of the cover page, where we have added the Society for Healthcare Epidemiology of America as a partner organization approving the adult schedule. The third edit is the list of adult vaccines, where we have removed PCV13 and included the 2 new pneumococcal conjugate vaccines, PCV15 and PCV20, in this list. The final edit is the addition of the QR code at the bottom right-hand corner of the cover page. After scanning this QR code with your phone, you'll be taken to a CDC website with the adult immunization schedule so that you can refer to an online version of the schedule from your mobile device if you prefer. We'll now turn to the changes recommended in Table 1 that outlines the age-based recommendations for adult vaccines. Table 1 has 3 proposed edits. The first edit is to the zoster vaccine row, where 2 doses of recombinant zoster vaccine are now recommended for adults aged 19 through 49 years who have immunocompromising conditions. This change reflects the new ACIP recommendation. The second edit is to the pneumococcal vaccine row. To reflect the new ACIP recommendation, the new pneumococcal conjugate vaccine and the polysaccharide vaccine have been collapsed into one row. Guidance for which vaccines are indicated for certain age groups is displayed by the corresponding colors and overlying text. The final edit to Table 1 is to the hepatitis B row, where the row now has changed to yellow up to and including the age of 59 years in anticipation of ACIP's recommendation for universal hepatitis B vaccination for adults up to and including 59 years of age. Those 60 years of age and older will continue to have risk-based recommendations, which is indicated by this purple bar. Let us now turn to Table 2, which is the medical indications table. There are 5 changes that are proposed in Table 2. The first change is to the header, where CD4 percentages are displayed along with CD4 counts to harmonize the way this information is presented in the child and adolescent schedule. The second edit is to the legend at the bottom of the table, where we have reworded the description for the color red in the legend. Red now indicates that the vaccine is contraindicated or not recommended. The third edit is to the zoster vaccine row, where 2 doses of recombinant zoster vaccine are now recommended to adults greater than 19 years of age who have immunocompromising conditions, including HIV infection. This change reflects the new ACIP recommendation. The fourth edit is to the pneumococcal vaccine row. Like in Table 1, all of the pneumococcal vaccines have been collapsed into one row, with colors and overlying text indicating which groups need which vaccine. Finally, the last edit is to the hepatitis B row, which is now entirely yellow, indicating that the vaccine is recommended for all of these risk-based groups presented here. We'll now turn to the changes presented in the notes section of the adult schedule. In each of the subsequent slides, I will walk through the notes section and explain the proposed changes in each of the vaccine-specific sections. For your reference, the page numbers of the notes section can be found in the upper right-hand corner. We'll begin our discussion with proposed changes to the COVID-19 vaccination box on the first page of the notes section. In addition to stating that COVID-19 vaccines are recommended within the scope of the emergency use authorization or biologics license application for the particular vaccine, we have added the phrase, or as otherwise recommended by ACIP and adopted by the CDC director to the sentence. Additionally, because we feel that clinicians would benefit from having this information here, we're including the hyperlink to CDC's interim clinical considerations for the use of COVID-19 vaccines. Let's move now to the hepatitis B section. In this section, we have described in detail the 2, 3, and 4-dose hepatitis B vaccine series. Additionally, based on the hepatitis B discussions from this morning, we'll include language about risk-based recommendations for adults 60 years of age and older. We now turn to the HPV vaccine section. In the final bullet of the routine vaccination section, we have changed the wording to increase clarity, where we say no additional dose recommended when any HPV vaccine series has been completed using the recommended dosing intervals. In the special situations section, we have added wording to the immunocompromising conditions bullet. We now say that individuals with immunocompromising conditions should receive the 3-dose series as above when initiating vaccination at age 9 through 45 years. Recommendations for routine and shared clinical decision-making are similar to those for persons without immunocompromising conditions. Finally, we rearranged the wording for the pregnancy bullet in the special situations section. The pregnancy bullet now says pregnancy testing is not needed before vaccination. HPV vaccination is not recommended until after pregnancy, and no intervention needed if inadvertently vaccinated while pregnant. We'll now discuss the proposed changes to the influenza section, which starts on the first page, but will continue over to the second page of the notes section. On the first page, we have changed the language to age 19 years or older in the first bullet. And we have added the hyperlink to the 2021-2022 influenza recommendation and a bullet for the 2022-2023 influenza recommendation. On the second page of the notes section, we have special situations listed for influenza vaccination. Much of this section has been condensed since we refer healthcare providers to the appendix to learn about contraindications and precautions for the influenza vaccine. We'll now turn to the MMR section on page 2 of the notes. Under the special situations section for the HIV infection bullet, we have added CD4 percentages in addition to CD4 counts to harmonize the language with the child and adolescent schedule. Let's move now to the meningococcal vaccine. The only change to this section is the addition of a note at the end that states meningococcal B vaccines may be administered simultaneously with meningococcal ACWY vaccines if indicated, but at a different anatomic site if feasible. We'll now finish with the third page of the notes section. The pneumococcal vaccination section has been substantially modified to reflect the new ACIP recommendations. We have a bullet now that states that those aged 65 years or older who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown should receive 1 dose of PCV15 or 1 dose of PCV20. If PCV15 is used, this should be followed by a dose of PPSV23. Once details about the dosing intervals between PCV15 and PPSV23 are finalized, we'll include a link to that guidance here. We'll also include a link for providers to reference the guidance for patients who have previously received PCV13 or PPSV23 in the past. The special situations section has also changed. We now have a bullet that states that those who are 19 to 64 years of age with certain underlying medical conditions or other risk factors who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown should receive 1 dose of PCV15 or 1 dose of PCV20. If PCV15 is used, this should be followed by a dose of PPSV23. Again, once details about the dosing intervals between PCV15 and PPSV23 are finalized, we'll include a link to that guidance here. And similarly, we'll also include a link for providers to reference the guidance for patients who have previously received PCV13 or PPSV23 in the past. The pneumococcal section ends with a note that lists all of the underlying medical conditions or risk factors that would make those aged 19 through 34 years eligible to receive pneumococcal vaccination. We'll now move on to the varicella section. Here, like in the MMR section, we have added CD4 percentages in addition to the CD4 counts in the HIV infection bullet to harmonize the language with the child and adolescent schedule. We finish this page with a brief discussion of the zoster section. In the special situations section, we have revised the language for the pregnancy bullet. Pregnancy bullet now states there is currently no ACIP recommendation for RZV use in pregnancy. Consider delaying RZV until after pregnancy. We've also added language to reflect the new ACIP recommendations for persons with immunocompromising conditions. This bullet now states that RZV is recommended for use in persons aged 19 years or older who are or will be immunodeficient or immunosuppressed due to disease or therapy. Let us now turn to the newest edition of the adult immunization schedule, which is the appendix that lists all of the contraindications and precautions to each of the adult vaccines. The first page of the appendix lists all of the influenza vaccines. To see this better, let's zoom in and look at all of the sections of this appendix. Here you can see the beginning of the appendix. We state that this appendix is adapted from the ACIP General Best Practice Guidelines for Immunization and from the 2021-2022 Influenza Vaccine Recommendations. We have also included a link to the interim clinical considerations for the use of COVID-19 vaccines, which lists the contraindications and precautions to COVID-19 vaccines. The first page of the appendix lists all of the influenza vaccines approved for adults. The second page of the appendix lists all of the other non-influenza vaccines. Again, let's zoom in to see this section in further detail. Here you can see the contraindications and precautions listed for all of the non-influenza vaccines. With that, thank you so much for your attention, and I'll pause here for questions.
Thank you, Dr. Murthy. This session is now open for questions. Dr. Sanchez.
Hi, sorry, I couldn't find the button. No, it's amazing the amount of information, and I commend you all for the great job. I just had a question on the adult one, actually, on slide 72, I believe, where you have the let's see, the conditions. So you eliminated, I think, the cochlear implant that was present in the childhood one. And at least I don't know if it wasn't there last year, I'm not sure. But I just wonder if it's clear, because you bring it up in the pneumococcal, I presume that it's also brought up with the influenza, the live attenuated influenza vaccine. And I just wonder if it's clear enough for the adults that the cochlear implants in patients and adults, if that should be included there as well.
Yes, thank you so much, Dr. Sanchez, for that question. I think the goal here is because there was so many different nuances with the contraindications and precautions to the influenza vaccination recommendations this year, that the work group decided to have a separate section for the contraindications and precautions in the appendix. So that kind of led to the discussion of the creation of the appendix. So if you look towards the appendix, I don't know if I'm sharing my screen here, the cochlear implants is listed as a contraindication for the live attenuated influenza vaccine. So we're trying to direct healthcare providers to really glean this information from this appendix.
No, I understand that, but when there's at least for me, when I see one of my patients with cochlear implants, I need to be alerted, or I want people to be alerted that they need pneumococcal vaccine, that they can't get this, they can't get that one. So it's the other way around, so that when adults see a patient with cochlear implants, to make sure that these vaccines have been given or not given, rather than, and that they've been updated completely on their pneumococcal as well. Not when they're thinking about giving pneumococcal vaccine and then they go to, oh, this one has cochlear implants, so they should get it. I just want to put the cochlear implant patient as an indication for a special situation that needs or does, and that there's some importance in their vaccination schedule.
Mm-hmm.
And that's not captured by this.
That is a fair point. I think that is something that we will consider for sure. I mean, here in the pneumococcal vaccination section here on slide 113, we do have that special note that mentions cochlear implants for those between the ages of 19 through 64 years that they should receive vaccination. But yes, we don't have an analogous appendix per se based on very specific risk factors other than Table 2, which, I mean, Table 2 does not have cochlear implant here, but it does have other risk factors, you know, that would indicate certain vaccines.
Okay. Ms. Bata?
Thank you. Also, back at the pneumococcal recommendations, in the notes, you say CURL. Is that what it's going to say, or is it actually going to include the interval? Because I would strongly request that you include the actual interval in the notes.
Thank you so much for that question. That guidance is still being discussed, and perhaps our colleagues from the pneumococcal work group who are on this call can maybe speak more to that. But our plan is to not have the actual phrase URL pending. I mean, by the time these schedules are published, which is hopefully in February of 2022, we hope to have a URL, and so we can direct healthcare providers to actually access that website and not have the words URL pending on the schedule. But as of this presentation, as of today, that guidance is still not formalized yet, so we can't have that explicitly written into the notes section as of right now. I mean, if we are, maybe perhaps someone from the pneumococcal work group can speak to that as well.
It's not necessary. I appreciate the fact that you don't have that information, and thank you for that clarification that you will be including it.
Thank you. I see Dr. Long would like to add something to this conversation.
It's not from the work group, but I had the very same thought. I think when it's easy to give the information, it's better to have it right there. And I think you'd only have to add about 3 words. So in the pneumococcal statement, when you say you could do 20 or 15, and if you use 15, it should be followed by PPSB 23, and then you can just put 2 weeks to 12 months with an interval of 2 weeks to 12 months, and the URL, or some indication for a few more words for the urgency of attaining the full coverage that you would want, for instance, in somebody with a cochlear implant is exactly what I was thinking. Or someone who's just had their spleen out. You don't want to wait 12 months, but you might wait to the next healthcare visit for someone else. So I think you could refer people, but it's always best if you can leave that put that information there if it's easy. And I think this would only be a few words. And the other one is the same thing about the process that's included only for the coronavirus vaccine and wasn't exactly followed. Thanks.
Thank you so much, Dr. Long. Yes, absolutely. We will work closely with our pneumococcal vaccine colleagues to see how we can best succinctly present this information in the final version that will be published in February of 2022.
Thank you. Dr. Daly?
Yeah, thanks. Thanks so much, Dr. Murthy. Could we go to the slide that talked about notes concerning HPV vaccination?
Yes, sir. Let me just pull that up real quick.
Dr. Murthy, we can't see. Oh, there we go.
Okay. I just pulled it up. Yes, go ahead.
Yeah, perfect. So I was a little confused about the statement that said recommendations for routine and shared clinical decision making similar to those for persons without immunocompromising conditions. And I don't know, I would just love to hear if others were confused by that, because I don't know if it was just that it was going by so fast, because I'm trying to think about what we're trying to convey here. Thank you.
So I would love for our HPV colleagues as well to chime in here, but the previous iteration of this, last year's version of this schedule had essentially, maybe I can pull that up real quick. It had, yes, it was for immunocompromising conditions, 3-dose series as above, regardless of age at initial vaccination. And that was a little confusing because a lot of people interpreted that oh, then you can really, since it says regardless of age at initial vaccination, you can start the HPV vaccination series at any age if somebody has an immunocompromising condition, 65 even, So I think to address that concern, we spoke with our HPV colleagues and came up with this language here, saying that recommendations for routine and shared clinical decision-making for those with immunocompromising conditions are similar to those for persons without immunocompromising conditions, essentially stating that you still need to fall within that recommended time frame, the age range, and it's not as folks were misinterpreting it from last year's schedule, that it's not completely disregarding the age range recommendation as presented above.
Okay, thanks for that. I mean, I appreciate the intent to clarify that, and I just was still a little bit confused by the reference to both routine and shared clinical decision making in the context of immunocompromising conditions, because that's sort of multidimensional. Those are sort of several different concepts. There's routine recommendations, there's shared, and then there's immunocompromising conditions. And I still am not entirely clear. But thank you.
Dr. Paling, you'd like to add something to the conversation?
I'm sorry.
Sorry, I saw Dr. Paling's thumbs up first, and then we'll go to Dr. Long, because I can see you want to add to the conversation. Dr. Paling. Dr. Paling, we can't hear you, or it might just be me.
I'm sorry, I'm double muted. Thank you. I'm going to agree with Dr. Daly that that's confusing. And part of it is the 9 to 45 is stated in the sentence prior, but it's not clear who that's referring to. And so maybe adding some clarity about to the age-based recommendations for persons 9 to 45, or something like that would help improve clarity for that. Thank you.
Thank you, Dr. Paling. We will work with our SMEs from the HPV section to clarify and see if we can reword that. Or if somebody from HPV is on the call, please feel free to speak to this.
And Dr. Long?
Yes, mine was the same comment, and I think the more indirect way you've said it is more confusing. I agree with everybody here that I would just say for people with immunocompromising conditions, don't talk about shared decision making. I wouldn't hear. I think you could just say that it's a 3-dose series, even if the first dose is given before 15 years of age. I mean, that's what you mean.
Thank you.
That is correct. Okay.
Yeah, I would just be very direct about that rather than trying to, the indirect way you said it, you're talking about two things, and and you really only want them to get 3 doses, even if they started before 15, where others can get 2. Thanks.
Okay, thank you. And I'll also agree with my colleagues' comments. I actually have one additional question, which is really for consistency's sake. I think it's on slide 72, but it's table 2 for the adult immunization schedule. It might be off on slides now. So if you go to the colored, there we go. So my question to you is if I look at the childhood immunization schedule and you look at the red box, which is either a contraindication or not recommended, it doesn't actually list, whether it's a contraindication or not recommended in the boxes here. It looks like it's not recommended everywhere. I am familiar that the pregnancy column really is not recommended until, after pregnancy is over. It's not a contraindication necessarily. I think it's not necessarily called that, but like, for example, LAIV and immunocompromised, or MMR and varicella and immunocompromised, I think of as a contraindication. and not a not recommendation. So I'm very confused why that labeling is there.
Hi, this is Dr. Woody. Maybe I can help. Last October, when we presented the schedule, we had the same comment, and just traditionally, the medical indication table has had more overlying text than the child schedule. So that's why we, even though the red you could infer from the legend that it's not recommended, we had the text listed on it. I think we've gone back and forth about it to remove the overlying text or not. Traditionally, the child and adolescent schedule doesn't have a lot of overlying text in the medical indication table.
Yeah, and just to be clear, my question is actually, isn't it contraindicated, some of the live vaccines? It's not just a not recommendation, it's actually contraindication, which I think of as distinct from not being recommended.
Yeah, and if we had, I think what my recollection from the last meeting is that if we start using different phrases, not recommended and contraindicated, that providers may find it confusing. So we landed with not recommended. Well, I understand what you're saying. It's actually contraindicated, not recommended.
Right. So I see that it's consistent in the childhood schedule, Dr. Woody, but I was curious about the adult schedule listed here on the slide, Dr. Murthy, and whether or not you could just take out the not recommended, since I think it's actually contraindicated.
Okay. We could leave it in the pregnancy column, but for the others, we could take out the not recommended. Is my understanding correct?
Yes, either it should be a contraindication, to be clear, or just take it out. One or the other will be fine, but I'm confused by the fact that it looks like it's not accurate as written up there.
Okay. So we'll take out, go ahead.
I was just going to say, Dr. Lee, so if I'm understanding correctly, you're saying for like the MMR and varicella pregnancy boxes, it should just be a red box. That's it. No overlaying text. Is that correct?
I mean, I think I'm more agnostic about pregnancy, in part because I know we've had these pregnancy conversations before, and sometimes we are silent in that we don't recommend it. And I'll point, I think that's specific to HPV. I have to go back to the MMR and varicella recommendations. But what I'm saying is under the immunocompromised boxes you see there, to me, it's not a not recommended, it's contraindicated. And not recommended is very different than contraindicated for me. And I think it has to be clear that it's a contraindication if you're immunocompromised.
I see. Okay, so it's just removing the phrase not recommended for immunocompromised box and stuff. Okay.
We can actually harmonize it with the child schedule where we take out all the overlying text, and then for pregnancy, we just leave the asterisk in the red box. Would that be acceptable?
Thank you. Sorry, I made my point. I'll go to Dr. Cotton.
Thanks. As somebody who takes care of immunocompromised patients, I think it would be helpful to just say contraindicated, not recommended, but contraindicated. That just makes it clear. So I would prefer that for immunocompromised, and then I defer to others about pregnancy, but I would like to make this obvious. This is relatively overwhelming at this point, and I think we need to really help active clinicians in the field who are trying to figure out this schedule.
Okay, thank you, Dr. Cotton. Dr. Long.
I agree with you all about this. Both LAIV, MMR, varicella, and MMR and varicella. Yeah, they should all be contraindicated. It's kind of weasel to say not recommended. And if you don't say anything, then people will think I can go ahead and give it because, you know, they're traveling or whatever reason. I think it should be contraindicated.
That sounds, Dr. Murthy, I think we just want to clarify the distinction between the evidence to recommendation framework that goes from recommend to shared clinical decision making to not recommend, do not recommend, but that those are all distinct from contraindications, which we usually put under the recommendation. And so we just want clarification that it's consistent with the currently published recommendations. But Dr. Alt, did you want to respond?
I just want to make sure I understand what we're saying, and I may not be understanding correctly, so you can correct me. So rather than having the text overlay that says not recommended, you'd rather it say contraindicated, where's contraindicated? Is that what
Correct.
you're saying?
Yeah, correct. Because
Okay.
it's along the way, I think it used to be contraindicated was a red box. Along the way, I think not recommended got added in over the years, which is a recommendation against or no comment, honestly, in the case, for example. I think that's true for HPV pregnancy, but somebody can correct me if I'm wrong. But that's a very different thing than a contraindication where we really do not want clinicians to give a live vaccine to an immunocompromised person.
Right. I think these two categories got collapsed a few years ago. So now we're going
exactly.
back to the opposite direction. So, okay.
Thank you.
That makes sense to me as well.
Thank you. Okay, so we're going to run through, we just have, I think, 4 more hands raised, so I'm going to go with Dr. Freihofer.
Sandra Freihofer, American Medical Association, and a member of the Adult Working Group, and a practicing internist who really appreciates having the word overlays on this document. So I just wanted to clarify. So you're talking about for MMR and varicella, changing the not recommended for immunocompromising and HIV less than 200 to contraindicated. Is that correct?
That would be my suggestion.
Yeah, and then what about the LAIV?
It should be listed under contraindications as well. I believe in the full guideline for immunocompromised.
So I think that would be very helpful. And on the key, it says not recommended / contraindicated. So I think adding the overlay actually adds clarity for a busy practicing internist. Thank you for those suggestions.
Thank you. Ms. Hayes.
Yes, Carol Hayes with the American College of Nurse Midwives. I think that I completely agree with you. Not recommended is an inappropriate language to use because it is completely contraindicated to give a live vaccine to a pregnant woman, to a pregnant person. And so we need to get rid of that not recommended language, and it needs to say contraindicated in the pregnancy column. I will defer to Dr. Cotton and everyone else about immunocompromised individuals. But for pregnancy, it needs to say contraindicated for live vaccines.
Thank you. Dr. Hoag.
Yes, thanks, Dr. Lee. Michael Hoag, American Pharmacists Association. The word contraindication is a big word for pharmacists because we deal with contraindications to drug therapies every day. Not to pile on further, but I totally agree that this needs to be crystal clear that this is contraindication and not just a not recommended. So I support completely that the language has got to be crystal clear that it's contraindicated here, especially given the increased role pharmacists are playing in administering some of these vaccines.
Thank you. Dr. Long and then Dr. Kane. So Dr. Long.
Yeah, I just to make it very clear, the HPV is different. That one can stay not recommended because it it's not live and it's different. It's not contraindicated. And I think your language said that, but don't take out all the, you should leave that one either with an asterisk to where you explain that under HPV, or leave that one as not recommended.
Thank you. Dr. Kane?
Yes, Dr. Long, that does make sense.
Dr. Kane?
Yes, so Virginia K. National Medical Association. I think sometimes, our colleagues, even though it's not recommended, they may decide in certain settings that, wow, I think you would benefit from this vaccine. And contraindications, especially for live viruses and HIV patients less than 200 CD4, it can cause serious complications if they receive that vaccine. So that's a huge difference between contraindication and just not recommended. Even though it's not recommended, I don't realize that this may be extremely harmful if someone receives this vaccine. So I think it's so critical that the contraindication is there so that they realize serious consequences happens if this is given versus just, it's just not recommended. But I think, in this case, this clinical situation, I think you might benefit from this, even though it's not recommended.
Okay. Thank you. And Dr. Freihofer and Dr. Alt, I don't know if you still have your hands raised, but we'll just take any new comments or suggestions.
I had one more question when it's my turn again.
Go ahead.
So I just wanted to clarify. So under the pregnancy for MMR and varicella, it should say contraindicated, but keep the star there because some of these patients are in we would want them to get vaccinated after pregnancy if they're not immune. And under the HPV, keep it not recommended with the star because we want them to, it's not recommended during pregnancy, but we do want them to vaccinate after pregnancy, but it's not contraindicated. It's just not recommended. And do you think that, so that was my only question. Was that what you're saying?
That is my summary of all the conversations, but Dr. Murthy, I'll let you respond.
Oh, no, I was just going to say, Dr. Freihofer, that makes sense to me. I think that having the text overlaid as contraindicated for MMR and varicella with the asterisk that says vaccinate after pregnancy and then having it as not recommended for HPV with the same asterisk, that makes sense to me. I think essentially, if I'm hearing this conversation, it's that all of the overlaying text gets changed to contraindicated except for the HPV pregnancy column, which still remains as not recommended. But every other red box just turns into contraindicated.
Okay. I'm only going to take one more question, which is Dr. Sanchez, and then we are going to close this session.
So just a comment, because the footnote has contraindicated for the red, contraindicated or not recommended. And so then it becomes important then that on the overlay that we actually specify the contraindicated versus not recommended. So I think the overlay print needs to stay, because otherwise we go back to that same, confusion. Comment. Thanks. Okay.
Thank you, everybody. I think we are going to shorten our break because we are running quite behind schedule. I'm going to 5-10 minutes. Okay, we're going to ask for 5 minutes. Well, why don't we go until 1:55? I'll give you 7 minutes. We can reconvene at 55 after the hour. Thank you.